So my claim is there are many medical comorbidities, medically co-occurring conditions in children with autism. Now, is this really true? Is my observation simply skewed by a sample I see? So this is data from a recent study. This is not the only study. There are several studies like this. This study looked at medical records from a large US healthcare system over 15 years. It's about 280,000 children, 3,300 of which, about 3,300 of which have autism. And it found three things that I want to point out. The area in the blue is, the area in the blue there, I don't think I know how to make this work. So the area in the blue is children who don't have autism and the medical conditions that they have. The area in red is medical conditions in children with autism. So if you can see, the area in red is significantly larger than the area in blue, saying that overall medical conditions are more prevalent in autism spectrum disorder. And even among these children, the electronic health records data, when it was analyzed, showed that there are three clusters among the children with autism. Some of them, about 50%, have a low prevalence of conditions. They may have one or two conditions at the most. Then there's a mid-prevalence cluster that has more medically co-occurring conditions. And then there's a high prevalence cluster. And some children have as many as 6 to 7 medically co-occurring conditions. So even among the children with autism, some are sicker than others, and children with autism overall are sicker than the general population. So why does this matter? And here's why it matters, and there's 5 things I'd like you to take away from this presentation. And I made way too many slides, so I'm going to rush through as we get closer to the end. But I'd like to just start with this so that you have the frame of reference. So as we know, autism is a behavioral diagnosis, but there are also significant disruptions in biology. It's essentially a multi-system, whole-body disorder. And these disruptions in biology are what cause the co-occurring medical comorbidities. These are more prevalent in ASD than in the general population, and as I said, some kids are sicker than others. The reason it matters is they impact both quality of life and mortality risk. The challenge is these medical comorbidities can present as behaviors, so it can be really challenging to diagnose. And if you're a therapist trying to work with a child with autism, if the child's acting out because of sinus inflammation, it just makes it that much harder for behavioral therapy that day to be effective. So the medical comorbidities do affect the therapy outcomes. So that's one very important reason for all of us to be aware of this. The good news is they are diagnosable and treatable, and treating these comorbidities can improve quality of life, mortality risk, as well as improve therapy outcomes. So again, as we know, the diagnosis is based on behavioral criteria, but there is disrupted biology. And these disruptions are throughout multiple body systems. The immune system, the brain, you can have inflammation in the brain, metabolism, the mitochondrial system, the gut microbiome, which is a newer and emerging area of research. We've documented through basic science research disruptions in many, many systems associated with autism. And I think we already said what comorbidities is. So how do we diagnose and treat? There are medical standards of care in autism. I tried to capture pictures of some of these. And the one on the left is from for family physicians. There's a bunch from the American Academy of Pediatrics. And this is not to denigrate anybody. This is simply to tell you what I've experienced as a parent. So I'll give you an analogy to explain how I feel about these standards of care. So to come to Trivandrum, I live in California, I went to Travelocity, I typed in which airport I fly out from, where I'm flying to, then I bought a ticket, drove to the airport, got on the plane. Well, you know how it works. These are like going to Travelocity and typing in the airport. It's a place to start. You're not going to read this and learn everything you need to know to treat autism. You know, for that, it takes careful clinical care. It takes paying attention when you're treating these kids. So I would say start here, but I think we can do a lot better than the current standards of care. So I mentioned that medical comorbidities can impact quality of life, and mortality risk. The risk can be more than twice as high compared to the general population. So one study on a fairly large cohort showed that it can be up to 2.5 times as high. And there's several studies that have followed these cohorts, and you can look them up. But the predictors of mortality are the level of impairment in early childhood, especially functional impairment. So that, I think, is really proxy for the so-called low-functioning children. I wanted to point out this quote from John Elder Robison. He is an autistic person himself, and he is an autism advocate. And the quote says, "Autistic people appear to die much earlier than the general population, and they seem to be far more vulnerable to a surprising range of medical problems." So again, I want to emphasize the fact that the medical comorbidities in autism are diagnosable and treatable. So on the left, I've shown the ICD codes. This is the International System of Classification for Medical Issues. And these ICD codes are from the electronic health record system that I alluded to earlier. So all of these are diagnoses seen in children with autism. On the right, I've put down some of the diagnoses that members in my group have experienced in their children. So you can see they cover multiple body systems, the brain, the mitochondria, metabolism, immunology, the endocrine system, and so on. So all of these were diagnosed through standard medical tests that you would find in any lab in the United States. Some need more specialized testing, but these were all diagnosed through completely standard ways. It can be hard to diagnose, as I said. And I borrowed this phrase. I think it is used in the UK in the context of depression a few years ago. And diagnostic overshadowing is where health professionals assume that the developmental disability or the psychiatric or mental health condition is really the cause of the symptoms, and they fail to give a thorough medical evaluation. As a parent and as an advocate, I have seen this happen over and over and over again in autism. A lot of times we're told, oh, it's just autism. So I would appeal to the clinicians here to please keep this in mind. When you see a child with autism, this is a child who could be pretty sick, and so it's not necessarily just autism. And I wouldn't entirely I don't want to give the impression that I'm blaming clinicians for this. It is challenging because a lot of autism symptoms, a lot of medical symptoms can present as just behaviors in children with autism. So I'm just going to go through a few examples. There's one child here that I am more than willing to talk about in excruciating detail because it is my own child. All of these others are not necessarily specific children. The photos are stock photos, and the cases I've mentioned here are a composite, if you will, of children that I've seen discussed on my group. So it's not any particular child, it's many of them. So this is a list created by a parent organization in the UK that wants to raise awareness around medical comorbidities and autism. And they've attempted to list all of the behaviors that may indicate an underlying illness or pain. And if you scan this list, you will see a lot of this looks like simply autism. So I'm going to go through just a few examples. So you have a spacey child, keeps staring off into the distance, and we know that children with autism have social deficits. So does this child have a social deficit, or does he have absence seizures? There's a 13-year-old on the verge of puberty who suddenly started acting aggressive. Now, 1 in 4 children with autism are aggressive. We know that. That's documented fact. So is this teen, does he have just autism? Or is it new onset temporal lobe seizures? How does the parent even know when to go to the doctor versus go to the behaviorist? And how will the behaviorist tell or the doctor tell? I think this is another reason to have really robust standards of care that recognize this diagnostic dilemma. So a 5.5-year-old has the flu, and a couple of weeks later, he suddenly has a regression in speech and skills. The parents may not connect the two. So should they just increase the ABA service hours? Should they try to do a behavioral plan to understand the antecedents and consequences, refer to an SLP, or work up for Landau-Kleffner syndrome, or all three? It's really hard to know. I've been in this situation. This is much more of a classic example. A child starts pushing up his abdomen against furniture. And it's pretty easy on the face of it to see this as stimming, repetitive behavior that is seen frequently in autism. But it can also be the only indicator you might see of abdominal pain or gastrointestinal distress. The tricky thing is these children also present very differently than other kids. You've got a kid that has been experiencing chronic difficulties. Very often, these kids are told that he's just withholding, and it's a behavior. But could it be constipation, which is a functional GI disorder seen in many kids with autism? The only way to know is if you are able to consider both possibilities and make the differential diagnosis, as it were. This is also my child. There's a picky eater, and he is failure to thrive, so below the 5th percentile on height and weight. So should we send him to a feeding therapist? Should we call this picky eating? Or should you check for causes of failure to thrive? You know, food allergies, malabsorption, digestive issues, enzyme deficiencies. Head banging and self-injury is very common. And should you work up physiological causes, or should you just refer for a functional assessment? Often you get referred for a functional assessment, especially in low verbal children. This is also my child. So is task avoidance, especially in the afternoon, warrant a behavioral plan, or could it be a mitochondrial energy deficit? And the last one, there's a kid that just moved to California, and he suddenly has this exacerbation in behaviors, you know, scripting, anxiety, self-injury. And so is this because he has to adapt to a new place? That's what the parents were told. You just moved, he's got a lot of adapting to do, he'll settle down, don't worry about it. It turned out that he had seasonal allergies with an total IgE that was 10 times the upper limit of normal. So I made it sound hard, but honestly, the accurate diagnosis is possible. My child has been extremely fortunate to have a team of clinicians who've helped make these diagnoses, so I know it is possible. The core concept here is that, yes, we do need behavioral therapies. They do help these children. My child has had behavioral therapies for 10 years, and I've actually increased the hours for both behavioral therapies and speech and language this year. But the behavioral treatment should not substitute for a medical evaluation. And a couple more things to keep in mind is parents generally try to give good information, but they may not always understand how to interpret the symptoms they're seeing, especially if they've been repeatedly told that these symptoms are just autism. Also, individuals with autism, even verbal individuals, won't necessarily say where the precise location of the pain is, and they may not respond in typical ways to common illness. For example, some of them have an inability to spike a fever. Some of them are immune deficient, so a lot of the symptoms you associate with an illness are actually an immune response, so they may not even present with those symptoms. So I just want to take a step back and present the big picture here. The population is increasing. This is not an esoteric disorder. It's 1 in 59 children. And as many as 30% may need 24/7 one-on-one care through their lifespan. It's a neurodevelopmental disorder, but it doesn't just go away. You don't age out of it. The costs of care in the US are skyrocketing. $250 billion a year is a lot of money. And there are no FDA-approved drugs. This isn't because we're not spending money on research. There's a very large research budget. We just haven't gotten there yet. The other challenge is that 500,000 teens are going to become young adults, and there is a need for transitioning from pediatric to adult care. This is the situation in the US, and I think it's the foreshadowing of the situation anywhere else with a growing autism population. We're also, as a parent, experiencing there's too few primary care providers, and they don't have the training. needed in order to make the differential diagnoses of autism behaviors versus autism comorbidities. And there's also skills needed in certain more basic areas like mitochondrial medicine or metabolism that we often find that there's a lack of. As a result, what we find is families are single-handedly managing and integrating specialist appointments, which they're absolutely not in a situation to do. It's very difficult being the point of care of your child's, for your child. That role has to be played by a primary care physician. And parents get burnt out as a result. The sad thing is, it's not that providers aren't trying. Many of them, up to 70% in a study, reported that they feel that they don't have enough to offer these families. So it's not a pretty situation, but I don't see it as really bleak. If we know it, I believe that we can fix it. So this is a little critical, but I felt the need to put it up there, and let me talk you through it. I don't think the issue, why do we not have FDA-approved drugs? I think there are two big reasons for it. One is structural, and the other is the fact that the autism spectrum is so heterogeneous. We probably need phenotypes that are not just based on a behavioral diagnosis. We probably need medical phenotypes and biomarkers. So that's one thing that gets in the way of any drugs being approved. And the other is that autism is a multi-system whole body disorder, but medical research often happens in specialty silos. And there isn't a really natural way to integrate all these findings into an evolving big picture understanding of autism. So there's this famous story about 6 blindfolded men and an elephant. And depending on what part of the elephant they're touching, they say this is what it is. And with no disrespect meant to anybody, this is how I view autism today, both in a clinical and research context. Lots of really, really good people, but not a good way to create interdisciplinary collaboration, whether in a clinical context or in a research context. I think if we change this, much of what I pointed out earlier will change. So I just wanted to quickly talk through some of the comorbidities that I've seen as a parent and how they impact children with autism. And we're going to do this in some fairly idiosyncratic order. Seizures are probably one of the most significant ones, and gastrointestinal issues are also a significant source of distress, but mostly because this is sort of what I like to talk about. So epilepsy is more prevalent in ASD compared to a non-ASD population, and in the literature, which I'm not necessarily going to quote here because that's beyond my understanding, it's possibly because there are many shared pathways between autism and epilepsy. So as an example, the prevalence in the general population is 1 to 2%. In autism, it's between 25 and 30%. And there's 2 peak periods when children are young, and again in adolescence, lots of people in adolescence see new onset seizures. And these, and then there are some patterns that seem to be peculiar to autism, in that the seizures starting after age 12 may be more prevalent in ASD than in other populations. So there's some kind of pathophysiology there that is driving this that isn't fully understood. So why does it matter? It matters for 2 reasons. One is epilepsy and autism can affect behavior, cognition, and communication. It can affect every single therapeutic goal that therapists work on. So let me quickly go through the story of this child. This is my child. So when he had an overnight regression at age 2.5, and at that time he had significant EEG abnormalities with spiking on both hemispheres. He went on to develop a mixed seizure disorder. He also had so-called rare presentations of what used to be called seizure syndromes, one called ESES, so status epilepticus in sleep. And how it manifested, obviously, if you didn't do an EEG, you wouldn't know all this. The way it manifested is he wouldn't walk on sand. He wouldn't want to be in a swing. If you were an occupational therapist, you would label it as a vestibular issue or proprioceptive issue, and it was all of those things. But OT wouldn't help. He just would cry and tantrum if we tried to get him to do anything. So it took a long time to figure out an anti-epileptic drug that would work for him, and it took a long time to get his gut to settle down enough to absorb it. Once we did, almost instantaneously, after his EEG cleared, he went from being nearly nonverbal to being verbal for his wants and needs. He was able to swing for hours, run around on the beach, and he continues to manifest very delayed speech. But we saw dramatic improvements in behavior, cognition, and communication just by treating this one comorbidity. So that was an anecdote, and the literature certainly supports this as well. I'm going to go through some of this fast. So here's a really important point I want to emphasize. Epilepsy significantly increases mortality risk in ASD. It is the #1 cause of premature death in autism. So this is an example that was published in Spectrum News, which is a news magazine devoted to autism. This is a child who died on his 17th birthday. He had never had a clinical seizure, and he had shown no signs of seizures except in his mother's eyes, and he died suddenly overnight. Seizures, and I want to skip to this to say, clinical seizures are not the only concern, and this is where really robust standards of care are needed. 25 to 30% have epilepsy, but up to 70% have EEG abnormalities. So the question I would ask is, how will you determine the sudden death due to epilepsy risk? Will you just look at the individuals with clinical seizures, or will you do EEGs on everybody to see who is at risk due to highly abnormal EEGs? How will we know? So this is the standard of care for seizures and epilepsy. EEGs are not recommended as routine practice. So there isn't really, I think, a good answer to my question. If anybody has answers, I would love to hear it after this talk. So I'm going to start talking really fast, and I'll jump to gastrointestinal issues. These can be huge causes of pain and discomfort in autism. For a long time, people denied that there were even gastrointestinal issues in autism. It was all seen as behaviors. So I will quote again the excerpts from the standard of care, which says anybody who presents with gastrointestinal symptoms should be given a very thorough evaluation, just as you would evaluate someone without autism. I went through 6 pediatric gastroenterologists in hospitals around the country, even to get a complete workup for my son, because more often than not, it was dismissed as that's just autism. So the symptoms that have been described are constipation, diarrhea, and what's called encopresis, where there's leakage of stool. And the GI abnormalities that have been described include inflammatory bowel diseases like Crohn's and ulcerative colitis, reflux, bloating, digestive enzyme deficiencies, and inflammation of the GI tract. So this section, again, I will go through quickly, but there are 3 takeaways. There are a wide variety of gastrointestinal issues in children with autism. Many, not all, are currently diagnosable and treatable. So if you're a gastroenterologist or a primary care physician, please keep this in mind when a child comes to you, especially if they've just started acting out suddenly. Children with autism do warrant a thorough evaluation, just as you would any child without autism, and they can be tough to diagnose. So these, I just wanted to juxtapose all of the findings in the research with what we've seen anecdotally on my parent group. We've seen a variety of things that may or may not show up in clinics around the country where the parents weren't taking a proactive role. So we've seen a lot of food allergies, and since anecdotally we know that food allergies can be connected to constipation, a lot of us go and ask proactively for a workup. So food allergies, and also non-IgE mediated hypersensitivity syndromes where the only way to diagnose is an elimination diet and a food diary. Also esoteric things like pollen food allergy syndromes where IgE allergies to aeroallergens causes you to react to foods. So you almost have to be a medical detective working with your primary care physician, going through all of these possibilities to isolate what is going on with the child. So this is a continuing list of diagnosed GI issues in autism. I will highlight one of them, which is small intestinal bacterial overgrowth. A very exciting area of study is the gut brain axis in autism, but quite independent of that, just small intestinal bacterial overgrowth, which is diagnosable through breath testing. Not a great test, but diagnosable through breath testing is often a problem in these children, especially children with immune deficiencies. And so you can just see this quickly. A lot of gastrointestinal issues present as behaviors. The standard of care for gastrointestinal issues in autism is actually really robust, and they've linked the behaviors to potential gastrointestinal issues. This is obviously not a complete list. I just put it up here as an example. I want to go through this quickly as well because allergies can be a huge cause of GI symptoms. It's both the IgE-mediated allergies that you would test with a skin test or a blood test, as well as non-IgE-mediated, non-immune-mediated hypersensitivities and non-IgE-mediated hypersensitivities. So just what I said, the top 8 allergens are a place to start, and the cross-reactivity is thing to remember. This causes not only gastrointestinal symptoms, but also really aggressive behaviors. I mentioned that the gut-brain axis is a new research frontier, and I think it's a very exciting one. So some other issues include sleep disorders, and the sleep disorders may be because they may have the same causes as sleep disorders in other kids, like obstructive sleep apnea, and you can use the same tools like anactigraphy or polysomnography in order to resolve them. My child had obstructive sleep apnea, and an adenoidectomy and tonsillectomy fixed it. So he was one of the more classic cases, but he continues to have a different sleep disorder that hasn't resolved by any of the classic methods. So a range of sleep disorders are present in autism, and this has all been recorded and documented in the literature. There is so much literature. If you put in autism as a search word into PubMed, which is a search engine for all of the research in autism in English, you get about 48,000 hits. There's a ton of research out there, and I really, really hope it will be integrated into more robust standards of care. So the reason there are sleep disorders in autism is that people with autism are more likely to have mutations that affect the sleep-wake cycle as well as hormones affecting sleep. So very quickly, immune dysfunction in autism is a very, very, very big area of research. I think it's probably one of the biggest, least studied areas. There are immune-mediated comorbidities. There's also pathophysiology in autism that has been seen through studies both in a variety of ways. And on the right are a list of diagnoses that I made of kids in my group. My son has common variable immune deficiency, and various kids on my group have one or more of these. The other 2 large areas are mitochondrial and metabolic disorders in autism. There are a variety of them. My son also has a mitochondrial disorder. He has one that's specific to autism, which was diagnosed on a muscle biopsy. But mitochondrial support has been amazing for him to regain some social skills as well as just energy to go from one activity to the other. And interestingly, it has been the thing that has helped most with his hyperactivity. I'm going to conclude with this slide on mitochondrial and metabolic issues. This itself probably would take 2 hours to do justice to it, and I would not be the person to do justice to it. But suffice it to say that these issues are much, much more common than one might think, and addressing it for a subset of children can be miraculous, and it can make them much, much more receptive to therapies. Thank you.